There we go. All right, welcome everybody to day 2, live in Denver with my friend, my very, very good friend, longtime Kim Davis from CU Medicine. Kim, how many times have you been on the show? Is this the third time?
I think
Fourth
this
time?
is the only second time.
Second?
Once during like COVID, we
yeah,
had to do
COVID
it
for sure, yeah.
virtually.
Yes, we did it virtually. I thought you were on. This was really only the second time.
This is only the second time, I think. Yeah.
Oh, that's my bad. That's on me.
Well, thanks for having me this time.
Well, of course, yeah. Well, you live here, so
Yeah, I do.
it's nice. It's nice when it's in your hometown. You can just come by.
It is nice. It does make you a little lazy. I'm not gonna lie.
Yes. I can see how that would be like. You're not going somewhere and you're in a hotel, so you're not feeling obliged to like go out after. You're like, no, I'm gonna go home.
Right? Oh,
Yeah.
yeah.
Nice. Yeah. So, what's going on in your world these days? You tell people a little bit about your organization because it's a little bit different. I could never understand the CU system at all. So
I know our model is really different. So, I serve as Chief Revenue Officer for CU Medicine, which is a faculty practice plan, and it is only the faculty practice plan.
Right.
We are affiliated with partner hospitals, but we are not commingled. So
commingled.
commingled.
Is that the word they use, or is that?
The school is independent and an independent affiliate. We staff Children's Hospital Colorado and the Anschutz campus, UC Health facility. And then various hospitals contract for coverage up and down the Front Range.
Sure.
We have several CU Medicine-owned freestanding clinics in the Denver metro area, but it's all pro fee.
It's all pro fee. And how many physicians does like CU Medicine have?
We have about 4,000 providers.
4,000. Okay.
Yeah, well over $1 billion in net revenue.
Okay.
Mm-hmm.
So 4,000 providers, and you're connected to these other systems like CU Health,
UC Health.
UC Health, and Colorado Children's, right?
And yep, Children's Hospital Colorado. Our child health providers staff Children's Hospital Colorado and sort of their network of care locations. And our adult health providers staff the Anschutz campus of UC Health and some of their other locations.
And do you bill everything for like those physicians that go there? They're still your employed physicians, right? They're just going there. So you're billing for them.
We're basically back-end revenue cycle starting with abstraction, coding, all the rest.
All the way through. Okay. Gotcha. And so what's like what makes the academic thing complex? Like walk us through a little bit of it. I mean, I know, but I've never worked in an academic like you have. So what are the things that are unique to the academic world? I'd be curious.
I would say a lot of cutting edge care for sure. We have a really cool limb restoration program. We have amazing research arm. And so, of course, the connection with the Office of Grants and Contracts and billing for research versus standard of care, things like that are nuanced in an academic center. And all different sort of compensation models, because each School of Medicine department is sort of like its own independent business, if you will. Overarching all under the school, but they're sort of in charge of their finances, their comp model, their own reserves. So, yeah, they're required to keep some reserves on hand, and they're financially responsible for making sure that their reserves are at an appropriate level to cover them for, over in a crisis, for example.
Wow. Okay.
Yeah. So there are all these, we have like 18 cognate departments that are all responsible sort of for their own finances, staffing model, incentives.
You just said a word I don't know what that means. Cognate?
Yeah, it's
Should I know what that means?
So what they share in common is the teaching and research mission of the School of Medicine. They're all like teaching departments.
So does that each have like a chair, and that's like the CEO or president, kind of?
They each have a chair that's like the CEO.
And is it broken up by like specialty, or is it the chair of, I don't know?
Yep.
Anesthesiology.
Yep. Chair of anesthesiology, chair of surgery, chair of radiation oncology, chair of psychiatry. And then under those are things that are called divisions within an academic practice plan. So right under surgery, you might have plastics and reconstruction, the limb restoration that I mentioned.
Specialties underneath all of those.
Specialties underneath those, yeah.
And so each one of those, you're saying, has to have their own P&L, own reserve model, own reserves and reserve model. But they all roll up. You're doing all the billing for all these people, right?
Yes.
Okay. But they all roll up to like a head chair? I don't.
No.
This is like a wild thing.
Don't.
I'm actually not.
They're all independent businesses, and so our customers, if you will, we make sure that we have 18.
18 chairs? And you have to make all of them happy?
Yes.
That seems impossible.
Lots of balls in the air.
They don't roll up to one CEO or a provost or something of the university?
The dean.
The dean. They do actually roll up. They all 18 report to the dean equally. That's crazy.
It is an interesting model.
Wow. I don't really know what to say. I guess I didn't realize it was like that. I would have assumed is there like you have a CFO, right?
We do. We have a CFO of CU Medicine. Yep. And we have
no CEO.
Dean of Finance, if you will, under the Dean of the School of Medicine. So.
Oh, but that's separate though.
Everything's separate in my world. The faculty practice plan reports to the Dean of Finance and Administration, and then he reports to the president of CU Medicine, which is the Dean of the School of Medicine. So we're like connected.
So you're really connected to
at the very top.
The university. And do you get funding from the university though? Is it then you have like state requirements that you wouldn't normally have, or no?
No.
It doesn't work like that. So it's still
funding.
separate.
We're a separate 501c3.
Because I know Heather was saying one of the issues that they had I won't say the name, but like another place that's similar was that the university and the health system were actually super connected. And then the university said that they owned any IP that was built, anything that was done at the health system, the university said they owned. So in other words, they say they had an invention, some doctor, or like in RevCycle, say they do something interesting, they're going to roll it out, spin it out into a company, right? Like a codometrics thing out of Mass General, right?
For sure.
But the university is saying that they own all that. And so they couldn't like sometimes do the things they wanted to do because they felt like the university was saying, well, no, that's ours. You owe us.
Yeah.
So you don't have that situation.
No, we don't have that. We are pretty independent from the school in terms of our mission is sort of to the extent, the clinical enterprise is able to generate and we are able to collect on, we are trying to fund the school's mission. But the university
has its own budget.
Has its own budget.
Yeah, okay.
And they're the ones that get the funds from state and federal, et cetera.
Right.
And
you're not giving some amount of money over to the university every year. They're not taking some kind of like, hey, we're taking 10% of the revenue regardless of.
Right. So the way the structure is, we take a contingency fee for CU Medicine's effort to pay for our staff.
Sure.
And then the dean has something called an academic enrichment fund. So he takes a portion of the collections. And then the departments get the rest.
So you're kind of like a separate entity in a way. You're kind of like, you're getting a contingency fee for collections. Wow. So do you have your own IT department then?
We have our own IT department. We have our own marketing department.
That you own? Like you run?
Yes. Yeah.
Does it report up to you?
Contingency fee pays for IT, it pays for marketing, it pays for contracting and health plan development, it pays for business analytics, and it pays for rev cycle, among other things.
So all the administrative functions are kind of separate from the chairs, right? And then does that roll up to like someone who runs kind of the administrative part? Like the CFO is like kind of like the end all be all in the administrative function?
For CU Medicine?
Yeah.
It's it's executive director who also serves as the dean of finance and administration in the School of Medicine.
Okay,
so he's got a foot in both.
Wow.
And then the dean of the School of Medicine, the dean, he is the president of CU Medicine, so he has a foot in both places.
Wow. I've never talked to you about this. I'm fascinated. People might be like, I don't know what's going on, but I'm like blown away. So what happens one time in my career I was over this big CBO. We had 17 hospitals. And I had basically I think I had like 6 or 7 CFOs that were, because they were all like some of this was like a system that had like 5 hospitals.
Yeah.
But ultimately, I had to report out. I had to talk to all these CFOs who didn't really want their CBO taken and centralized, right?
Yes.
And so I had to it was like the worst part of the whole job was to try to have those monthly calls. Okay, well, here's what happened, and then they'd be like, "What's going on? Why are collections?" So what happens? You have 18 of those.
Mm-hmm.
So what happens if you got a rogue chair who's just off, going crazy and making a lot of noise?
We do have some squeaky wheels, and generally the department with the squeaky wheels are more procedural in nature, higher amounts of revenue being billed per provider. And so we try to keep in close contact with them. We try to keep in close contact with everyone, but we certainly try to make sure that we are aware of any issues that they're encountering before the dean is. Just and probably everyone else's situation.
I guess.
Yeah. But
other people have departments to worry about, but they don't have as much power, right? Usually it'll come to the CFO anyways, and the CFO kind of be like, okay, well, they can kind of mitigate it, right, a bit. But your situation, you don't really have that. You have to really kind of smooth it over to all 18.
I have a team of 11, what we call client managers. And
you do.
Their job is to talk to the division heads, talk to the chairs, talk to what's called a director of finance and administration, which is like a CFO sort of
in each
department. Each chair has the DFA. Yeah.
Okay. Oh, that makes sense.
And so their job is to just stay out there.
So that's the person
in the community and keep their feelers out. Talk to them about their revenue cycle metrics, go through where there's opportunity either on the front end or on the back end. Try to have transparent conversations about what's happening in their revenue. Oh, we have too much over 90 days, and here's what we're seeing the problems are, and we're working on that. Or you need to get with your hospital partners on their front end because your authorization write-offs are going through the roof. They're out there just trying to make sure that we are being communicative, transparent, all the things.
But you don't own the access, folks?
Nope.
Oh my God.
We don't own any of the access stuff.
But you do have centralized, I don't know, clearance function probably, right? Scheduling? Do you have scheduling? You must have scheduling. No.
No, in our freestanding clinics, we have scheduling, but we work off of each hospital's Epic EMR. So that the scheduling,
yes,
the RTE, the pre-auth, all of it happens in the hospitals, each of the hospitals' versions of Epic.
Got you.
Mm-hmm.
But you don't have a centralized scheduling, I want to call up, I want to get an appointment with physicians, a CU medicine physician.
The hospital owns centralized scheduling, and if we have a freestanding clinic, we pay them for that use of that department, yeah.
And then you're on what system?
We are on
different systems?
Athena IDX, yeah. Children's was a very early adopter of Epic.
Yes.
So they have their own instance of Epic. UC Health was a little bit later, and they have their own instance of Epic, and they actually look very different. Because I think Children's implemented Epic sometime before I got there in 2007, a very early adopter of Epic.
Yeah, I think I knew that.
Are you looking for a judgment-free revenue cycle space? Do you want to expand your revenue management skills and learn insider strategies? Check out RevCycle 101. Unlock the foundations of healthcare finance with RevCycle 101, a comprehensive course designed to give anyone, from a recent graduate taking their first professional steps to a seasoned sales leader refining their expertise, the clarity and confidence to excel in revenue cycle management. Through easy-to-understand terminology, practical tools, and proven methods, this course demystifies the complexities of the revenue cycle. It equips you with the skills to drive results, optimize operational efficiency, and significantly advance your career in the shifting realities of today's healthcare industry. Click the link in the description for more information. Now back to the show.
I was talking to somebody yesterday, and they were like, well, we implemented Epic in 2000. Oh, John Nakirk.
Oh.
Freighter. He said they implemented it in 2002. And I was like, 2002?
Yeah.
He's like, but we are in their backyard. I was like, that makes sense. But I was like, holy cow, that's early.
Yeah.
He's like, yeah, it was, because especially the rev cycle side, Epic, the clinical side was earlier, but like the rev cycle side was built for PB. So it actually probably was fine on the PB side, but
yeah.
it's interesting. So you don't have much connection with like Sadaf and Candace, like from the two different organizations. Those are VPs of rev cycle at both places. For those who don't know.
Yeah.
You're not like talking to them all the time. Like, hey, what happened here?
I talk to Sadaf a couple times a month.
Okay.
Yeah.
All right. Okay.
Probably. I talk to Candace a little less, but I talk with her peer, Robbie, all the time. He's more front end guy. And so.
Because you're having to deal with front end issues, right? So you don't necessarily like.
Right. No control, just
influence
collaboration.
Model.
Yep.
Yeah.
Influence model.
Okay. Wow. That is so different. I guess I didn't realize how different it really was. That's interesting.
Yep. It's very unique.
So what are the things that you're spending, like, what are you spending time on? Like that's you're like, oh man, like we're spending so much time on this. Like there's gotta be a few of those that other people would be like, I'm not spending time on that.
Yeah. We, with kind of in obstacles around revenue cycle reimbursement, we spend an inordinate amount of time on out-of-state Medicaid. Children's Hospital Colorado really wants to be a regional destination.
Oh, right.
And because of that, there's a lot of focus on kids, Medicaid, et cetera. So we have a lot of resources around enrollment,
that makes
maintaining enrollment. Lots of states will drop you. Lots of out-of-state Medicaid issues. Yeah, that I think is kind of unique because of that strategy.
Yes, that would be rough. And there's got to be a fair amount of like financial counseling at the hospitals, right?
Yeah.
But even then, it's like trying to figure out. There'd be a lot there.
In Colorado, we have this relatively new, not brand new, 2023 maybe, legislation that requires the facilities to ask all patients who enter if they would like to be screened for discounted care, a discount effectively. And if a patient says, or a parent says, yes, I need to be screened for a discount, they have to go into a holding pattern. You cannot send statements unless they are insured. Then you can bill the insurance, but you cannot bill the patient or the guarantor. And effectively, they have this like 6-month window to gather all the information, fill out their application, get their paperwork in order, and get it back to the hospital's financial counseling team, who then says, do they qualify for a discount or do they not? And then you can bill. That's a very simplified explanation. But it sends a lot of AR into a holding pattern for up to 225 days.
It's kind of like pending Medicaid.
It's kind of like pending Medicaid.
And do you hold that? You just hold that in AR, or you count it? You don't count it in AR.
You hold it in AR.
Okay.
Yes.
There was always a debate. I remember this debate for a long time because we had a lot of pending Medicaid. This is back in the days of pre-ACA, right? And so it was all disability, basically, unless they were a child. So there's a lot of debate about whether to hold it in AR or to actually make it a zero balance until you get them, until you get coverage or figure out what to do.
Yeah. Yeah. So that program has really, to your financial counseling question, really required our hospitals to flex that financial module in Epic and use it to its full extent, as well as lots of presumptive eligibility write-offs in there.
Totally.
Yeah.
So anyone that comes in, even if they have insurance, can say, I want to be screened for a discount.
Yep.
But the language there has to be confusing, because if you told me I could qualify for a discount, I'm going to be like, yeah,
huge volume.
Can I qualify for a discount?
Yes.
Absolutely. Let's have this conversation.
Huge volume. Because they just don't know. And then they start getting asked for the paperwork, and they just ignore it because they don't necessarily need it. They just thought that would be nice if I could get a discount.
Absolutely. Yes. But you're holding it.
Yep.
So do you get how many how many days in AR are you roughly
I think 41 right now.
40? I was at 40? Okay.
Mm-hmm.
Of the 41, how many days are holding in that situation?
When we calculate, we give ourselves a break and calculate HDC excluded. It's generally 4 to 5 days. Yeah.
HDC, that's the holding.
We take that out and remove it from all.
What does the HDC stand for again?
Hospital discounted care.
Okay.
Yeah.
But it's 5 days basically.
Mm-hmm.
Holy crap.
Yeah. Not insignificant. Like I said, it's confusing because people say, yes, I would love a discount.
But that doesn't include pending Medicaid though.
It doesn't include pending Medicaid.
Because that's another couple days, probably, right?
Mm-hmm. Just that massive hospital discounted care program. Yeah.
And then, so how do you guys do, how do you kind of manage patient collections? That comes to you, even though on the front end, you're not doing the clearance functions. In theory, the hospital is. I mean, your freestanding clinics, obviously, you're collecting on balances, in theory.
Mm-hmm.
But it all comes to you at the end, though, right?
Mm-hmm.
After adjudication, you're going to, have to send out statements.
Mm-hmm. Yep.
And how do you manage, the CU Medicine, Colorado Children's? Because you're only collecting the balance for the physician, and you've separated it somehow?
Yes. So
does that get complicated? It feels complicated.
Part of the patient series of notifications includes we staff CU Medicine providers. You'll get a separate bill, all of that. And as a rule, there's a little bit of confusion, but you would be surprised. We don't get very many complaints or questions about that.
You don't have a problem with balances. You're getting the balance wrong because of they made a payment here, it didn't transfer over. I don't know. I'm just thinking of the natural issues.
No,
nope. Not happening really.
No.
Okay. Well, that's good.
And the hospitals, because of the No Surprises Act and the need to give patients estimates and all of that, they can't collect copays for us because it somehow messes with the math that Epic uses to calculate patient estimates. I have no idea how it works, but both hospitals were we can't collect your copays anymore because it screws with the estimate, changes the math on the estimate somehow. And so they haven't been collecting our copays for, I guess we're working on at least 2 years. And honestly, zero impact to our total patient collections, interestingly. People that are going to pay, and we just get it a little bit later, right? After insurance
delayed,
adjudicated instead of before.
Well, yeah. I mean, it's kind of makes sense, I guess, because, as you know, I mean, you're going to pay your physician bill way before you pay a hospital
right.
bill. So if it's my copay and it's $50, I'm probably paying it.
Well, I think Kelly had the same experience,
yes.
Right? Yeah.
I think that's interesting. I don't know what the Epic issue is, though. I have no idea what must be messing up some kind of expected reimbursement.
That's what I think.
Model.
Yeah, because the hospital's trying to give their own estimate And if they're collecting money from the patient that is not theirs, it's still going to factor into the math. We were really worried. We called Epic and we're like, is this true? And they said, it's true. So
yeah, it's interesting.
But it hasn't had any impact. As a matter of fact, our patient collection efficiency was the highest it's ever been just last year.
Well, I didn't mean to like take us on this academic medical center tour or academic medicine tour, but it was interesting for me. I loved it. I want to ask you one more thing before you go. I know you're really, really big on leadership and building people and helping them and mentoring people. Like that's your thing.
Yep.
I've heard from every single person I've ever talked to that says you're amazing at it. What do you think that the key, if you were to give advice to like other leaders on like what it is that you do that you think, like what would you say to people?
I think first I would say explore servant leadership. Like even if you're not heavy into Christianity, I think that the basis of servant leadership is absolutely the groundwork for a great leader. Because
how did you define servant leadership for us?
As a leader, my primary responsibility is to lift up those around me, lift up my team, lift up my leaders, whatever I can do to make them successful, make them challenged, make them feel rewarded. That's my primary role. And so if you were to ask me about anything we're doing in the automation space, I could give you like the 30,000 foot view. I could not tell you anything about the details.
We need Jen for that.
Yeah. Because that's what my team does.
Right.
And I remove their obstacles and I make sure they have what they need to have a fulfilling career. And same for my leaders above me and my peers next to me. I'm here to serve. How can I make your life easier? How can I make it better? How can I make you more successful? So I think that's that whole mindset is key. And then know that culture eats strategy for breakfast, right? Culture will change the trajectory of your organization, and it will change your life and all the lives of the people around you.
And you can lose it in 10 minutes.
Culture is, it's fickle. You got to be careful.
You can build it for 5 years and lose it in 10.
Yeah. Just like they say you can't over communicate, you cannot pay enough attention to culture.
That's great. I love what you just said about the beginning about servant leadership. I wonder so those of you who don't know, I go through this model. I use this model and I'm curious to know your reaction. I've never asked you this. I go through this model of like balancing challenge and support. It's a challenge support matrix, which you've heard from me for many years now. But you just said basically that, and I wonder when I went through it the first time, were you like, oh, I do this all the time, or what was your reaction? Or were you like, oh, I didn't, or did you put two and two together? This is actually what you live.
No, I was so excited to see it because I agree. It's so critical. It's critical. And that is, if you focus on that, the culture kind of comes naturally, right? Culture flows from you focusing on, right?
You're empowering people.
Because you're empowering people.
For those who don't know, it's like support is on one axis, challenge is on the other axis. And if you're all support all the time, it's a cozy culture, right? Like it's too much support is like, but too much challenge is like you're just burning people out. And if you could balance the two, what Kim is describing is this empowerment culture.
Yep.
Where she doesn't have to know everything that Jen does in the automation space.
Right.
Because she's empowered Jen to go do it.
Yep.
So, I love it.
Very blessed.
Kim, you're a great leader, great friend. Thank you for doing that.
Thanks for having me.
I really appreciate it. It was awesome.
It's been fun.
All right. Thanks so much.